Good day, everyone. My name is Jack. I welcome you to today's APSC CME webinar in collaboration with the Transcontinental Coronary Imaging and Physiology Club. Today's focus is a Fellows Focus Teaching to the Basics. The date stamp for today is 14 August 2021, 2 p.m. Singapore, Hong Kong time. This event is endorsed by the Singapore Cardiac Society as well as EBAC for CME Point, in collaboration with our industry sponsors. A disclaimer and some housekeeping, the content of this webinar is copyrighted by the APSC. The views expressed here are those of the faculty and do not necessarily represent those of the APSC. Currently, the event is live streamed through Wonder Medicine, APSC Facebook and YouTube pages. CME points will be accredited to attendees who are connected throughout the whole duration of the webinar. You will receive your certificate of attendance sent by email post-webinar. Please feel free to click on the Q&A boxes below for your questions, and the moderators will direct your questions accordingly. Now I'd like to call upon today's moderators to talk a little bit about TCIP as well as the program for this afternoon. Ho Lam, please.
Thank you, Jack, and good afternoon all. I'm Lam Ho from Hong Kong Tuen Hospital. TCIP is actually just a loose interest group under the APSC. These are our good members. We have the specialists in intravascular imaging all around the world, from Asia, Europe, South America, Australia, and America. And we in a group of cardiologists, we try to promote the intravascular imaging in AP region and also all around the world. Jeff, could you please go to the next slide? In our groups, we divide into two committees. One is for education. We aim at doing some webinar, some fellow course, and to promote and to share the tips and tricks in intravascular imaging use. And we also have a scientific committee led by the three young and energetic cardiologists from Singapore, Hong Kong, and Malaysia, Dr. Clin, Dr. Lee, and Dr. Tam, from the three major universities in AP regions. And they are supported by a group of experts all around the world. And I hope we can have some contributions to the cardiac field, cardiac society. And next slide. Today, this is our first function is as a fellow course. We will talk about the basics. The aim of this section is to share basic principle and application of IVUS and OCT in daily clinical practice. Today, we are very honored to have a group of real experts in imaging to share and give comments on different lectures. The first one is Dr. Alan Chen. Alan Chen is the Cath Lab Director in Queen Elizabeth Hospital in Hong Kong. He is a real expert in intravascular imaging. Dr. Cui is the highest volume of OCT in Hong Kong and is also an expert in intravascular imaging. Dr. Jia Haibo was the #1 CTO operator in China. And Dr. Satoshi Honda and Dr. Kim are my good friends. Dr. Kim just received FACC and FESC, and Dr. S.V. Lee from Malaysia, and Dr. Sidney Low, currently the chair in Interventional Board in Australia, and Dr. Yoshiyasu Sensei is also an expert in intravascular imaging. Paul, I think I don't need to introduce. Everyone knows Paul, and he was the course director in APAC, and I know APAC is coming back. We will have APAC again soon. And James Zhang is the author of the Ultimate Trial and expert in bifurcation. He will join us a little bit late because he's engaged in our life. And I will pass the time to Dr. Ahn to introduce the program of today.
Thank you, Dr. Ram. So I'm very honored to be here, and I'd like to thank you to Dr. Ram to construct a very educational program like this. And then I'd like to congratulate the great opening of our first meeting of TCIP. So I'd like to introduce shortly this program. Today's program is composing of six lectures. I cannot say thank you enough to all presenters to accepting and preparing today's lecture. The first three lectures are the IVUS Basic and Application in Daily Practice by Dr. William, and short recorded live cases for IVUS by Dr. Frankie, and OCT Basic and Application in Daily Practice by Dr. Chi Yong, and short recorded live case for OCT cases, Dr. Frankie again, and Common People and Limitation of IVUS and OCT by Tom Johnson. And last lecture will be the interesting imaging case sharing by the Christopher Jensen. I'd like to introduce the first speaker. So Dr. William Howe will talk about the IVUS Basic and Application in Daily Practice. Dr. William Howe, please.
Thanks, William. Perhaps you can start. We see it well. You can unmute yourself now.
Dr. William, you are muted now, so we cannot hear you.
Can you hear me now?
Okay. Yes,
okay,
yes,
good.
yes,
okay, thank you, Dr. Ahn. Okay, today I'm going to talk about IVUS basic and applications in daily practice. Also, I cannot move. I need to go out and come back again. Strange. I need to stop. See, I need to go out first.
Sure. You can stop share.
Yes, strange. Okay, I need to come back. I don't know why it happens. Okay, let me see. Okay, so today I'm going to talk about IVUS basic and application in daily practice. Coronary angiography has been the gold standard for the assessment of coronary artery disease. But the problem is coronary angiography is only a luminology. It only shows us the contrast filling lumen and nothing else. And while for intravascular ultrasound, not only allow us to visualize the vessel lumen, but also the vessel wall together with all the disease inside the vessel. And that is the reason why intravascular ultrasound is a more reliable technique in the assessment of coronary artery disease than coronary angiography. Right now in the market, we got couple companies got this IVUS technology. We have the iLab and Boston Scientific. This machine can do both the 40 megahertz IVUS catheter and the 60 megahertz IVUS catheter. And we have the Philips Volcano with the core machine. And this machine can do the solid state IVUS catheter and the mechanical IVUS catheter. And we also got this HD IVUS from Assist. This machine can do dual frequency on one single catheter. So with the 40 megahertz and 60 megahertz transducer on the same catheter. And also we have this VC Cube from Toronto. This machine got a dedicated IVUS for the CTO cases. And also we got this TVC imaging system from Infraredis. This machine can do the lipid scan with the conventional IVUS. And also we got this Novocyte from Kodafi. This machine can do both OCT IVUS on one single catheter on the same machine. And honestly, to me, all these good machines, if you know how to use it right. Otherwise, they're just like white elephant sitting in your cath lab. And when it comes to IVUS catheter technology, currently we got two different types, with the solid state and the mechanical. For the mechanical type of IVUS catheter, it consists of one single transducer located at the distal end of a motor driving cable. And I call this catheter as a high frequency catheter because the frequency is using up to 60 megahertz. And we got a single transducer located at the distal end of this motor driving cable. It rotates 1 second, 30 rotations to capture the IVUS images. But the problem is for this kind of IVUS catheter design, it got an air space, it can trap air. That's why we need to flush to get rid of air bubble. If there's air bubble inside, we cannot get good IVUS image. And the other problem is with this kind of IVUS catheter design, the guide wire is outside the transducer. That's why we got this guide wire artifact when you do the IVUS pullback. And the other problem with this kind of IVUS catheter design is that we got this NUR. NUR stands for non-uniform rotational distortion. It occurs during non-homogeneous transducer rotation when the lesion is too tight or when the vessel is tortuous. It can happen. And the other type of IVUS catheter design is a solid state. So it got 64 transducer located at the distal end of the catheter, and you automatically switch one by one to capture the IVUS image. This is a much user-friendly system, but the image resolution is not as good as the mechanical type of IVUS catheter because the frequency they're using is only 20 megahertz. So for IVUS, for coronary artery, it consists of 5 layers, and the most inner layer is the intima, followed by inner elastic membrane, and then the middle layer is the media, and then followed by external elastic membrane, and then the outermost layer is adventitia. But the problem with the conventional IVUS is that the resolution at the moment is still not that good. We cannot see all the 5 layers. The most is 2 to 3 layers. Intima is a thin non-echogenic layer, and the thickness is about 100 micron. When the patient is young, we don't see this layer very clear, but when the patient gets older, we can see this layer much better on IVUS. And media is the middle layer of an artery, which is composed of smooth muscle cells, contains very low collagen. It's echolucent or hypoecholic in nature, and the thickness is about 200 to 300 micron. So most of the time, we can see this layer very clearly on IVUS. The dark band here is the media. And the outermost layer is the adventitia. This is the outer layer of an artery, which is composed of collagen and elastic fibers, and is highly echogenic. And for IVUS, we want to see the plaque. Currently, we can differentiate the plaque into 4 different types. The first type is a soft plaque, mainly lipid deposit, echolucent in nature. So we compare the echogenicity with the adventitia. If it's darker than the adventitia, then we say this is fatty tissue. So in here, we got eccentric fatty tissue, and here we got concentric fatty tissue. And the second type of plaque is dense fibrous plaque. It contains a lot of collagen, which fibrous tissue produce dense and bright echoes without acoustic shadowing. Okay, so for example, if you look at here we got the fibers. Here we got the fibers. So we can compare the echogenicity with the adventitia. If the echogenicity is very similar, then we say this is fibers. And the third kind of plaque is calcified lesion. Okay, and for calcium, because the density of calcium is very high, it's blocking the ultrasound signals. The ultrasound cannot pass through. That's why we got this acoustic shadowing effect. Okay, and we know that calcium prone to dissection during angioplasty, and we may have difficulty in stent delivery, and associated with greater risk of stent underexpansion and stent fracture, and all this lead to poor clinical outcomes and higher MACE rate. And compared to cholangiography, IVUS is a much better technology in assessing calcium. And also, the last kind of part is a mixed part. There's a mix with everything. So we got calcium in here, bioecho with the acoustic shadowing, and we have the fibrous tissue here, we have the fatty tissue here. And here we got the calcium, acoustic shadowing, fibrous tissue, and fatty tissue. And this is the kind of part we're seeing in the Cath Lab every day. So now the question is, can IVUS to be used for non-laminar lesions for ischemia? Okay, within the last 20 years, we have quite a number of studies trying to correlate IVUS MLA with the FFR findings. And in the early days, we used the FFR 0.75 as a color value, and our Japanese colleague, they find that the best IVUS MLA color value is 3 millimeters square. So that is for IVUS measure the MLA less than 3 millimeters square. If you try to do FFR, the chances of getting a FFR less than 0.75 is much higher. However, for our European colleague, they find out the IVUS MLA is 4 millimeters square. And then in the later days, okay, we changed the FFR color value from 0.75 to 0.8. We also got different studies. And the IVUS measured MLA vary from 2.36 to 3.09. But the problem is, if you look at the diagnostic accuracy, it's not really that high, only around 70%. So I think that's too low for clinical decision making. And for example, when we look at the Dr. Koo study, okay, so for Dr. Koo study, they found the IVUS MLA is 2.8 millimeters square. So if we have the lesion IVUS MLA less than 2.8 millimeters square, there's still a number of lesions with FFR more than 0.8. So based on all the existing evidence, what I can only say is, for IVUS measure the MLA more than 4 millimeters square, the lesion will most likely doesn't cause ischemia. However, for measure the IVUS MLA less than 4 millimeters square, we cannot say the lesion will definitely causing ischemia. So when it comes to assessing the physiological significance of a non-laminar lesion, the best technology is FFR, not IVUS. And how about Lap-Min? So when it comes to Lap-Min disease IVUS assessment, this is what the European expert consensus suggested. So for example, if you have a Lap-Min lesion, you do IVUS. If the IVUS MLA is less than 4.5 millimeters square, we can have the patient go for vascularization because most likely this lesion is causing ischemia. However, if you do the IVUS MLA measurement and it's more than 6 millimeters square, then most likely this lesion is not causing ischemia. We can safely have the patient go for medical treatment. However, for IVUS MLA in between 4.5 to 6 millimeters square, we should go for physiological assessment technique like FFR or IFR for final clinical decision making. And for distal Lap-Min lumen area assessment, always assess the distal Lap-Min disease from IVUS pullback of both the LAD and circumflex, not just do IVUS pullback from one or the other. For example, here we got a distal Lap-Min lesion. If we do the IVUS pullback from the LAD, the MLA here is 3.45 millimeters square. However, if we pull back the IVUS from the circumflex, now the distal Lap-Min MLA becomes 5.69 millimeters square. So it's bigger. Since IVUS can artificially increase but not decrease lumen dimensions, so the smallest MLA should be used for final clinical decision making. For osteolesion, if you want to assess the vessel dimension of the side branch osteum, you should do IVUS pullback from the side branch directly. Don't just pull back IVUS from the main branch to assess the vessel dimensions of the side branch osteum. So, for example, if you pull back from the side branch here, the vessel dimension is circular in shape. Okay. However, if you pull back from the main branch, try to assess the side branch osteum. Now the side branch osteum become oval in shape. And it's the same. If you want to assess the osteum of the main branch, you should do the IVUS pullback from the main branch. Don't just pull back IVUS from the side branch and to assess the vessel dimension of the main branch osteum. So it's the same thing here. If you pull back from the main branch, the osteum is circular in shape. However, if you pull back from the side branch, try to assess the main branch. Now the main branch osteum become oval in shape because the cut planes are different. So this can overestimate the vessel dimensions, and as a result, you can oversize your stent, and that can be a disaster. So now the next question is how to choose stent size based on IVUS. I think we can use the suggestions from the European experts as a reference. So this is what they say. We should look into the distal reference and then either use a distal mean lumen diameter or use a distal mean EM diameter. If you use the distal mean lumen diameter, we can up rounding stent by 0.25 millimeter. So you use a distal mean lumen diameter for your stent size, we can upsize the stent by a quarter size. If we use a distal mean EM diameter, we can down rounding to a nearest 0.25 millimeter stent size. Okay, so now we have data from Korea shows that for Lap-Min bifurcation, after stenting, we need to achieve at least stent area of 5, 6, 7, 8 millimeters square. On the osteo circumflex, need to be at least 5 millimeters square. On the osteo LAD, need to be at least 6 millimeters square. On the distal Lap-Min, need to be at least 7 millimeters square. And on the proximal Lap-Min, need to be at least 8 millimeters square, based on the IVUS finding. Otherwise, the clinical outcome is going to be very poor. However, we also have data from Caucasian study showing that for Lap-Min bifurcation, after stenting, we need to achieve at least stent area of 6, 7, and 10 millimeters square. So on the also need to be at least 6 millimeters square. On the LAD, need to be at least 7 millimeters square. And on the Lap-Min, need to be at least 10 millimeters square, based on the IVUS findings. Otherwise, the clinical outcome is going to be very poor. The IVUS criteria are different between the two studies, can be because of the body weight and size are different among the Caucasian and the Asian. As the heart weight correlates directly with the body weight, thus a smaller IVUS stent and expansion criteria is enough for the Asian, but may not be enough for the Caucasian. So now we know that IVUS predictor of DES thrombosis and resources stent and expansion or standard lumen is too small. And edge problems like geographical miss, secondary lesions with large part burden, more than 50%, so it means your stent is too short. So you need to use IVUS after stent implantation to make sure the stent is fully expanded with good apposition. And also make sure you have good lesion length coverage. Otherwise, the chance of getting in-stent resources or late stent thrombosis is going to be very high. And IVUS can also very useful in help us to select the stent length. So we should try to cover all the part burden with more than 50%, okay? Otherwise, the chance of getting edge resources is going to be very high. And also, we try to have our stent longer than the calcium. Don't put your stent just on top of the calcium, just land on top of the calcium. If that happens, then the chance of getting edge dissection is going to be very high. And for plaque with very healthy calcium, we should consider calcium debulking first. Otherwise, the stent is not going to expand fully. So now we have so many different clinical trials out there shows that the use of IVUS improve clinical outcomes. And I would like to mention these 3 trials here. The first one is the Ultimate trial from China, and the other trial is IVUS XPL from Korea. And both of these 2 trials are randomized control trial, and also the ADAPT-DS. And ADAPT-DS is the largest observational study, including over 8,000 all-comer patients. And the result of these 3 studies shows that IVUS guided PCI compared with angiographic guided PCI reduces the risk of cardiovascular death, target vessel failure, and also major arrest cardiac event. So what is considered good stent deployment? I think we can follow the ultimate IVUS defined criteria. And these criteria are after stenting, the minimum lumen cross-sectional area in stent segment should be more than 5 millimeters square or 90% distal reference lumen CSA. And the second criteria is plaque burden at the 5 millimeter proximal or distal to the stent edge should be less than 50%. And the last criteria is no edge dissection involving media with length longer than 3 millimeter. If we follow the ultimate IVUS criteria for stent optimization, will lead to significant reduction of target vessel failure during 3 years follow-up among all comers. And also, IVUS is very useful for post-stent assessment. We can use IVUS to check whether we got any residual pus in stent margins, whether we got any hematoma. And here is the IVUS image of hematoma. So we can see the media is in here. So the IVUS catheter is inside the true lumen. And here is the false lumen with the hematoma. And IVUS is also very useful to check stent under expansion, tissue prolapse, and also incomplete stent apposition. And IVUS is also very useful to check for edge dissection. So in here, we got an edge dissection on IVUS. So in compared to core angiography, IVUS is a much better, more sensitive technology in detecting all these problems. So as a summary, ladies and gentlemen, this is what I call the Williams IVUS guided PCI protocol. So if there's an angiographical lesion, we should go for IVUS. And I already show you IVUS is very useful for pre-intervention assessment. We can use IVUS to assess for lesion severity, but of course the best is FFR. And also we can use IVUS to assess the plaque morphology. And for plaque with very healthy calcium, we should consider calcium debulking first, otherwise your stent is not going to expand fully. And IVUS is also very useful to help us to identify stent landing zones. And IVUS is very useful to help us to select the stent size and length. And IVUS is also very useful for doing intervention. We can use IVUS to identify stent-related problem like severe underexpansion or severe malposition. And then from there, we can decide whether we should go for high pressure or bigger balloon for post-dilatation. And I already show you IVUS is also very useful for post-intervention. We can use IVUS to identify stent-related complications like edge dissection, intramural hematoma, or tissue position. And for dissection length longer than 3 millimeter, and if dissection, tissue prolapse, hematoma is affecting the blood flow, we may need to consider to put in another stent. Thank you for your kind attention.
Thank you very much, William. So why don't you have some question now or the end of the first 3 lectures?
Maybe we can have some discussions. Cindy, do you want to have some comments on?
Yes, look, thank you, William. That's a wonderful talk. I really learned a lot and I think it's fantastic. So I want to make just simple comments, particularly since the fellows aim. I think the more that we do in training, particularly for the younger fellows, the better it is, because IVUS does take time to learn how to read. The one thing you haven't mentioned in your slides is about co-registration. So I think that it's come into play, particularly in OCT, but also I think it's very useful. And it's a bit more difficult with co-registration. It is available for the Volcano system, the Philips system, but it's only with the plug-in Eagle Eye, and so the resolution is not great. But the co-registration is very useful. And the other thing is MOD Max. I think we've heard, of course, about OCT and using this algorithm called MOD Max, which kind of makes it easier conceptually to think. One of the key things is pre-interventional IVUS. Probably it's not just good enough to do the post. If all possible, do the pre, because the morphology read helps you about your calcium, your landing zones, and that's where the co-reg really is very useful, because sometimes you can't tell. You can do a poor man's co-reg with the IVUS catheter and then taking an angiogram, and then at the distal landing zone and the proximal landing zone, and then actually getting a measurement of the length of the stent you might need, and etc. And I think those things are very good. I think that and the other thing is measuring. Basically, I think I'm guilty of for a long time just eyeballing the things, but measuring takes a bit more time on IVUS compared to OCT. And of course, it lends itself to doing ultra low contrast PCI when you actually just believe the IVUS. The more you do, the more comfortable you are leaving angiographic abnormalities, which minimizes stenting and other things you might need to do. So look, I thank you very much. It's a fantastic talk.
Okay, thank you for the very good comment from Sydney. I think for all the fellow, there also a question from the floor. We do the PIFS mainly to determine the size of the stent and the length of the stent. So do you have any, we can ask our panelists, what do you think about the accuracy of IVUS in measuring the length? What's your experience? Do you have any tips and tricks to use IVUS to measure the length of the lesion or decide the length of the stent?
Or you have a comment?
Maybe I'll chip in here a little bit. I echo what Sydney said. I mean, it's a fantastic lectures, and I certainly learned a lot. And I've always had Williams as my IVUS mentor, and I remember him helping us launch the IVUS service in my hospital before. I want to add one more point is I think sometimes doing IVUS is not an extra burden in terms of making the procedure more complex and making the procedure longer. In fact, the more you do, you find out that you actually save time and get a better job if you do it as a routine. I also like the fact that the IVUS is a really useful tool to palpate the lesion, if I can use the word, especially in calcified lesion. If your IVUS catheter cannot cross, then sometimes that you are facing a problem such as you may have to consider the rotablation and all that. So it's actually also very, very useful tool as such. But I think in particular, using the IVUS, saving the contrast, giving you a lot more confidence in your sizing of your devices is fantastic. Then there is the talk about the accuracy of the measurements. Obviously, the diameter and all those are perfect, but I think if you use the auto pullback in the common device, that's Boston device, the length of the lesion can also be pretty accurately measured. And Sydney also mentioned about the co-registration, using co-registration, sizing the length of the lesion is also very useful. Certainly something that I think for the fellows, the more you do, the more you get like it.
Ellen, yeah, thank you, Paul.
Yes.
Ellen, do you have some comment?
Yes, great talk, so William, and I also enjoy very much. So for the length, I think for the determination of the length, I think nowadays we have several versions of IVUS. So traditionally, for example, Volcano one, you have some markers on the catheters, so you can really make use of that markers in terms of 5 millimeters interval, and then you can measure the proximal as well as distal reference, which you capture on the cines, and then try to measure the approximate length. This is approximate. For the Boston one, you can do the calculation pretty more accurate. And nowadays, I think if you have chance to get a Terumo one, this is a very accurate measurement. You can choose your reference and then zero it, and then measure it both above or or by pulling back at once. And then you can measure the both proximal and distal reference, and then exactly calculate the length from the machine. So it depends on what IVUS version. I think in there's much more versions of IVUS available in the market. So when you try to use more, and then you get close to estimation. Some of the version you can get pretty much accuracy of length. So exactly where you're going to land, for example, ostium, just a side branch, and then beyond the calcified or moderate lesion, and you can pretty much get a decent estimate of the length.
Thank you, Alan. Because of thank you very much, Alan. Because of a time restriction, we have to move to the next talk. Dr. Frankie Tam is giving us the next talk, the short recorded live case for IVUS. Frankie.
Okay, so can you hear me?
Yes, I can hear you.
Okay, so yeah, so thanks for inviting me. So it's nice to be here to show you all a very short recorded live case for IVUS in PCI. So I enjoyed Dr. William Howe's talk. So actually what I want to do here is how to apply what William has said in doing a simple day-in-day-out PCI procedure using IVUS. So this is the patient's history. So it's a 77-year-old man, history of hypertension, hyperlipidemia, and sleep apnea. He was once admitted for central chest pain. At that time, the ECG showed some T inversion, but the troponin was normal. So he was diagnosed as not a non-STEMI. So he was discharged, and a CT angiogram was performed, which showed stenosis in LAD, OM, and RCA. He was stable. So the plan is to go ahead for elective coronary angiogram with the PCI using a right radial approach. All right, so this is the case. So this case was performed by Dr. Anthony Wong and myself. So this is the angio on the right side. You can see it's not very severe stenosis, but some mild to moderate diffuse stenosis in the proximal, mid, and distal RCA. So that's the aerial wheel. And this is the cranial wheel. Again, you can see that the multiple atherosclerotic plaque, but seems that not very severe stenosis as mentioned in the CT angiogram. So to the left side, so you can see there's some, this is the right aerial caudal wheel. You can see some, again, mild stenosis in the circumflex and obtuse marginal. And also some stenosis in the LAD. And you can appreciate that this is the cranial wheel. And now you can see this more severe stenosis in the LAD, which we think it may explain the symptoms and account for the ECG changes. This is the T inversion in the anterior disc. You can see text stenosis in the distal LAD, and also some stenosis in the mid and proximal LAD with some disease in the diagonal. And this is the air wheel, cranial wheel, as this is the hemiaxial. You can see, although the catheter dislodged, but you can still appreciate the stenosis in the distal LAD and the proximal LAD. So this is the day-in-and-day-out PCI case, not very complex, but this is what we usually do. We like to use intraoral imaging in all these cases. So we use the XP 4.0 guiding, 6 French, and then a wire, horse wire, and then we do the IVUS. So this is the thermal IVUS as mentioned by Alan. This is a thermal auto wheel IVUS. So you can appreciate there's a fast pullback, automatic pullback of the IVUS from the distal LAD to the proximal LAD. And this, you can see this pullback is just for 2 to 3 seconds. And afterwards, we can know how we can use IVUS to facilitate the PCI. So we determine where is the lesion and also where we would like to land the stent. So this is the distal LAD lesion. So this is the actually the landing we are trying to get for the distal LAD lesion. So as Alex has mentioned, we can use all this to mention the lesion length and also the size of the distal landing and the proximal landing. So now we are going to look at the proximal landing. And now we go to the proximal LAD lesion. And as mentioned by William, actually you can see the IVUS image is a little bit downgraded because of some AI artifact here. So in this case, actually the best thing is to we pull out the IVUS catheter, refresh the catheter, and do the pullback again. But still, although the image is not the perfect, but still we can appreciate the vessel size, plaque morphology, and also the stent landing. So this is now in the proximal LAD lesion. We can see quite extensive atherosclerotic plaque, and we are measuring the length of the lesion and how we want to land our stent. So this is the distal landing of the proximal LAD lesion. So we can see the vessel size is 3.5 here, the vessel size. Yeah, 3.5 and 3.6. So here we can actually put in a 3.5 stent, or if you want to downsize, we can do a 3.0 or 3.25 stent. And you can see that the total length of the proximal LAD lesion is around 56 millimeter. So now we come to the distal LAD lesion. So distal LAD size 2.7, 2.8, and the proximal landing we can see is around here. So the total length is around 12 millimeter for the distal LAD lesion stent. So now we go to the proximal LAD again. So we try to locate any good landing zone of the proximal LAD lesion stent. So you can see, but however, we can see that the atherosclerosis is quite extensive in the proximal LAD. We can see we almost found plaque all over the proximal LAD extending to the ostium. So you can see very heavy plaque burden here. So this is very common scenario that we see nowadays, because most of these patients, they have very extensive atherosclerotic plaque. We want to know where we should land our stent. So for the distal landing, is quite confident that it is here. For the proximal landing, we try to see whether we can use one stent to tackle the proximal LAD stent. So we try to extend from for 48 millimeter, because 48 millimeter is the longest stent we can get nowadays in a shelf. So we want to see whether we can land our stent in the proximal LAD, just 48 millimeter proximal to our stent. So in this case, so we first tackle the distal LAD. So we use the NC 2.5 balloon for pre-dilatation. And then as the IVUS has mentioned, we put in a 2.5 and 12 millimeter drug-eluting stent. So we put in a stent here. We can use co-registration as mentioned by Sydney, and sometimes we use the side branch as our co-registration. So in this case, we put a stent and we do post-dilatation NC 3.0. This is the measurement we get from the IVUS as in the pre-PCI IVUS measure. So we post-dilate the distal LAD stent with an NC 3.0 balloon. So and then we prepare our proximal LAD lesion, because there's so much plaque burden. We use a scoring here. We use the NC 3.0 15 score flex, and we dilate it at high pressure. So again, very high pressure balloon inflation. And actually, we can have a discussion on whether we want to protect the diagonal branch here. Okay, so as I've mentioned, we try to see whether one stent will be enough here. So we use a 3.5 48 millimeter. So all these measurements we can get from the IVUS. So we deploy the stent 3.5 48 millimeter stent. And then we do some post-dilatation after we deploy the stent here. Also, we post-dilate with NC 3.5 millimeter distal, and then proximal, we post-dilate it with a 4.0 stent. So if you remember, actually the proximal landing of the stent is actually on area that have quite a plaque burden. We really have to see whether we may have any stent at the section there, and also we need to identify the stent. Okay, so this is a post-stenting IVUS, so we can just see the distal stent is not very bad. And now we go to the proximal LAD stent. All right, this is the IVUS, and we can take a look at it very carefully. So the distal stent edge is quite nice. So the edge, the section here, we can see it frame by frame. And the expansion is not very bad. But you can see in the mid stent in the distal LAD, you can see that the expansion is suboptimal. You can measure the MSA, or you can just look at the diameter. It's just 2.0. So the stent expansion in the distal LAD stent is not satisfactory. So it means that we have to do something. At least we have to do some high pressure post dilatation in the distal LAD stent, particularly in the mid stent here. Right. So after this, we will go on to the proximal LAD stent. So again, the distal landing of the proximal LAD stent is okay, but just take a look at the proximal landing of the proximal LAD stent. We can see the expansion is not bad, but however, we can see that the landing is struck at area that have quite a lot of plaque burden. You can see it here. Although we don't see any obvious damage to the section, but the plaque burden here is quite significant. So as remember from William's lecture, we try to cover all the plaque burden. If not, at least we will try to land our stent at the area that the plaque burden is less than 50%. So in this case, it seems that the plaque burden is huge, that we have to do something there. All right, so as for the prosthetic IVUS, we know a lot of information. So what we do, we get an NC215 balloon to get an extremely high pressure balloon inflation. In this case, remember, we get a 24 to 26 atmosphere post-dilatation, so as to get a very good expansion. So again, we can get angio. Probably we have to do something here to put an understand to try to cover the proximal AD plaque. So in this case, what we did is we have to put another stent, 4.012, and we want to land our stent just at the ostium. In this case, we use the so-called Sabo technique. So maybe some of you would be happy to share the technique here. So in this case, we put in a 4.0 stent, try to cover the proximal AD plaque and land just at the ostium. So this is the post-stenting IVUS. You can see now the proximal stent, we are much more confident that we covered most of the plaque. At least we don't want to land our stent in the area with a significant plaque burden, because at that time, the stent failure, the target lesion revascularization or stent edge problem, in segment problem will be, a chance will be very high. So that the stent failure will be high. So now the distal stent expansion is much better. We can see it's much more rounded, and we can also measure the stent area, and the proximal can see is also much better. So this is the final results. So I can't say it's perfect, but at least from the IVUS we can see this patient has a satisfactory MSA, and also the edge is also quite okay. So I think this is the end of the case. So this is again the caudal wheel, the angio, the stent just land at the osteo-AD. This is a little bit MSA is satisfactory here, but on the IVUS measure is okay. So I think we can let it done. All right. So this is the end of the case. So see whether you guys have any comment or idea about this day and day out simple IVUS guided PCI.
Thank you. You have demonstrated excellent use of IVUS in PCI. Maybe we try a different way. Maybe we can see Japanese doctor. Do you agree with this style of IVUS use in daily life? And we can also ask the European doctors to see what is their opinion on this sort of IVUS usage. Yeah, Honda Sensei, do you have any comment?
Yes. First of all, thank you for sharing the excellent case, Dr. Frankie. I think this is a very good case under the guidance of IBIS images. So I have a question about the stent deployment on the LDN ostium. So you use Sabo technique to guide the best position of stent deployment. I think we can use IBIS for co-registration technique, so IBIS marking technique to optimize the stent location. Did you consider that method?
Yes, so that's a very very nice technique. Yeah, so personally, I don't have a lot of experience of this IVUS. Really co-registration deploying the stent. Probably maybe you can share your experience. But in this case, why we use Sabo is that because on the angio, it's not easy for us to really find a really good angiographic projection to really see the third ostium. So in this case, I think using Sabo may ensure us to really cover the whole area of the ostium without protruding a lot to the the left main. So maybe you can share your experience of using the IVUS co-registration, how to really can nail the stent in the ostium.
Yes, so yes, so I think Sabo technique is one of good methods to optimize the stent location. But there is some case where there is mismatch between coronary angiogram and the actual landing zone of based on IBIS image. So IBIS co-registration technique. So we call that technique as IBIS marking technique in Japan. We can confirm the accurate position on coronary angiogram to optimize the stent's position. So, and it's not so difficult method. So I recommend to, especially young doctors, to perform IBIS co-registration technique, especially in the very, like this case, so a very austere region, because the location of stent is very important. So that's my comments.
Okay, Dr. Johnson.
Yeah, so I just for the benefit of the fellows, I wonder whether we should expand on those techniques. So the Szabo technique, meaning that you're lifting a strut of the proximal stent and placing a wire through the cell, so that then you have placement on the ostium. And then Satoshi, the co-registration with IVUS, you mean to take an angiographic still frame at the point that you want to deploy, so you see where the IVUS marker is sat? Or do you mean using a large 7 French and having an IVUS in situ in the side branch to then visualize the stent? I'm guessing you mean just a co-registration angio acquisition. You're on mute. Satoshi,
you're on mute. You are muted, so I can hear you.
Sorry. For the IVUS marking technique, first move to the IVUS transducer as the position of proximal reference on IVUS cross-sectional image, and all you have to do is just do coronary angiogram as the location with the guidance of so just do coronary angiogram, and we can make a landmark of stent position with the IVUS transducer.
Yeah. So I mean, as Dr. Lowe said, the importance of co-registration actually is critical in terms of understanding where you are within the anatomy. I mean, Frankie, what you've shown is a most beautiful case, but also incredible confidence, which for a fellow or someone starting in the techniques, there's so much to think about. It becomes very difficult, and that idea of maybe using the MLD max algorithm, having some framework to use in your pre and post imaging intervention is really important. So you showed beautifully looking at the morphology, considering the stent length and the landing zones, and then making an assessment of the diameter for choosing the appropriate stent. And then very nicely in the subsequent imaging showed that understanding of looking for apposition, malapposition, looking for adequate expansion and for evidence of dissection. I must say, in my practice, I probably wouldn't have extended the stent proximally just because there was plaque burden. I think we often have to accept that we're landing stent into diseased vessels. And I guess there's a trade-off between extending your stent, the risk of malapposition in the left main versus the stent being in an area of plaque burden, but that's for further discussion, I imagine.
Yeah, that's true. Yeah. So how about what the other panels think? So will you extend the stent to the ostium?
I think it depends on the situation and depends on the physician's preference. So as mentioned before, it's a kind of trade-off. So if a left main is there is no plaque or the very mild minimal disease, I don't need to cover the left main itself, because I fully agree with your previous stenting strategy. So I have only one comment. What is the usual practice pattern of IVUS interpretation? I think most the physicians interpret IVUS after finishing pullback. But I think during the pullback, you have to co-register the coronary angiogram and IVUS pullback immediately in our brain. I think it is very important for the beginners of interventional cardiologists. So that is kind of practice. If we can do it, we can reduce the procedure time. We can reduce our error in measurement IVUS evaluation, I think.
Yeah, that's a very good question. So yeah, I think your approach is also adopted by many doctors. For example, Anthony, yeah, your approach. So for example, in the past we used the Boston pullback is 1 millimeter or 0.5 millimeter per second pullback. So at that time we always look at the IVUS pullback image and the angio. So actually we will know what stand, what length, what size to do after we do the pullback. But nowadays, we now have this thermal IVUS, or actually the OCT. We adopt this after the OCT thing. So I think it depends. I think it depends who are trained with. I mean, or develop your habit or your idea of whether we want to do the interpretation during the pullback or you want to do it after the pullback. I think, but again, both of these are very important and are very useful. I mean, to use the imaging data to have the PCI.
And Dr. and do you have any comments?
I have one comment for the audiences, especially fellow. So when I use the IVUS, especially LED penetration for the interpretation, is very difficult. Is the brain co-registration on a patient on the table. So it's at that time is I put this another guide wire is the diagonal branch. So that is the landmark, and we assume where is the IVUS is the co-registration is the angio. So that is one of my tips. Especially sometimes we struggle with where is the IVUS frame on the angiogram, very difficult to the co-registration. So it's another just one put this guide wire in the side branch is then make easy to the co-registration is IVUS and the angiogram.
Okay, so
do you want to make some comment?
Yeah, thank you, Frankie. Very nice live case and recorded case and demonstration. So so this is a quite long LED lesion with very diffuse disease. And so do you think any role of imaging physiology assessment, like if we fix a very tight lesion, and we just a question like Tom raised. So we don't need put a proximal lesion. So, but we need maybe as evidence. So do you think like imaging based physiology like QFR or wire-based FFR assessment for the very distal lesion and proximal lesion?
Yeah, sure. I think physiology will also be very useful in this case. For example, if you do a QFR, FFR, or IFR pullback, we may know which lesion is more significant. I mean, which have a deeper step up to determine which is the more severe lesion. But on the IVUS, this actually, I didn't show the MLA before the stenting, but they are quite tight, I would say. So we just want to save to open and physiology wire, so just open the IVUS and perform the PCI to both the proximal and the distal lesion.
Okay, thank you, Frankie. And Chris, Dr. Christopher, do you have any comment?
Yeah, thank you for presenting this very nice case, and I think it's a perfect case to show why we should use more imaging. First, diffuse disease is always hard to define the target zones and the landing zones of the stents, and how long the stent has to be, and what the diameter, the final diameter, should be, because it's so diffuse disease that you always underestimate the stent diameters and sizes. And the second thing is, well, you have to be, especially as a young interventionist, you're always reluctant to cover ostium and cover left main. And for me, to spare left main and go straight to the vessel, the only reason is whether I can image the left main and see there is no disease, because the angiography is always misleading. And most of the cases, if there is a plaque in the ostium LAD, for example, it always reaches in the left main, and you get trouble if you try to avoid placing a stent in the left main afterwards, just because you're reluctant and you fear that there could be a problem. It's sometimes simpler to go for a left main straight. But if you have imaging, then and especially if you're lucky enough to have co-registration, and you can clearly see where the disease ends, and you feel and you see the images where you have to cover and what sizes, then it's way easier and safer afterwards to place the stent in the ostial LAD in this case. So a great case, two excellent teaching points, a couple of excellent teaching points, and this makes you more comfortable and more safe afterwards in your treatment strategies. Thank you.
Thank you, Chris. Yeah, final words. I think before all the IVUS measurement for fellows, during your training, it's very important you predict, you expect what's the length, and then use the IVUS to match, see if there's any deviation from your expectation in your heart. That will help you to progress quickly. And maybe I pass the time to Dr. Ahn to introduce our next speaker.
I fully agree with Dr. Ram's final comments, and very hot discussion. I cannot interrupt the presenters and panelists discussion, but we have to move to the next session, next talk, so OCT basic and application in daily practice. Dr. Chian Chin.
Hi, I trust you can see my slides. So we move on now to optical coherence tomography, OCT. And I've been tasked to give the talk on OCT, basic principles and how we can apply what we know about OCT into clinical practice. So I'm one of the cardiologists at the National Heart Center in Singapore. So just some very basic principles about OCT. So the basic concepts of how we get an image from OCT is kind of similar to IVUS, which Dr. William Hauck very kindly explained for me. But instead of using ultrasound with IVUS, we use near-infrared light waves for OCT. So essentially, whatever waves that are emitted from the transducer gets reflected back by tissue, and this backscatter is then processed into an image. Now, the key thing about OCT that everyone should know about and probably already knows is that light waves are attenuated by blood. That means that the waves, when they encounter blood, the energy gets absorbed by the blood, so nothing penetrates through and nothing gets reflected back. That is why we have to clear the vessel, clear the lumen of blood, in order for us to have an interpretation or an image on OCT. So this blood clearance can be performed using contrast most commonly. Sometimes you can use saline as well. So in terms of technical differences between OCT and IVUS, OCT or light waves have a higher frequency, and with a higher frequency, we get a higher resolution of our image. So OCT has a much higher resolution as compared to conventional IVUS. The high definition IVUS brings ultrasound closer to light, but you can still see that OCT is of higher resolution. OCT also offers faster pullback of more than 20 millimeters per second. Conventional IVUS machines can only go up to 1 millimeter per second. Obviously, there are faster pullbacks these days, up to 5 to 10 millimeters per second. But as you can see, OCT can complete your pullback in a much shorter amount of time. And also because OCT gives us such clear pictures, thus the software can perform certain measurements and certain analyses automatically. That helps us to perform certain measurements. It gives us the lumen profile, which we'll see later on. There's also the co-registration function with OCT. There are these apposition and expansion indicators, which are semi-automatic with OCT as well. And OCT also provides us with a 3D reconstruction of the vessel, which can be useful sometimes. IVUS, by virtue of having a longer wavelength, has a better tissue penetration. So tissue penetration of IVUS is up to about 8 millimeters. With OCT, it's less than that. So if you have a very big vessel, a very thick plaque, then IVUS has a higher chance of you seeing the entire vessel as opposed to OCT. And of course, with IVUS, there's no requirement for blood clearance. And I think that gives IVUS maybe a little bit more versatility and a little bit more of a wider range of use. You can use it for aorto-osteal lesions, subtotal occlusions, CTOs, and patients with CKD as well. So this is just to illustrate the importance of a good blood clearance. On the left, you get it's an example of a vessel that has been cleared of blood very well. So you can see that there's a very clear demarcation or delineation between the lumen and the vessel wall. On the right, you have all these radio echolucency floating around. This is swirling of blood from inadequate blood clearance with contrast. Just a quick point about this, because people, like the fellows always ask me in the lab. So on the OCT catheter on angio has 3 dots. So there's a distal dot here that corresponds to the distal catheter tip. There's a middle dot. This is where the camera is, or where the lens is. You can see that for OCT, there's a bigger or longer distance between the distal catheter tip and the camera as compared to most IVUS systems. It's a little bit more dead space, so sometimes you can't reach very distal or very far down into the vessel. And this proximal dot indicates a length of about 54 millimeters between the middle and the more proximal dot. So this kind of indicates where your pullback would end if you were using the shorter pullback run of 54 millimeters. So there are 3 pullback options. The survey mode gives you a 75 millimeter fast pullback. You get about 5 frames for every millimeter of vessel. And it's, I guess, the most useful for our day-to-day clinical use. You can see more of the vessel, and there's enough information for you to make all your measurements accurately. The high resolution mode is a shorter pullback, but it is a slower pullback. And because it's a slower pullback, you get more frames per millimeter. So you get more assessment of the tissue per millimeter of a vessel. So you use it more for research purposes, or if perhaps your lesion is only very short, or if you want to perform 3D reconstruction after the pullback. There's also a stationary mode, which I find not always very useful. On the stationary mode, the catheter does not move, or the camera does not move, so there's no pullback, but it allows you to have a static assessment of a particular point of interest in the vessel. And one of its uses maybe is in trying to identify myocardial bridging. So this is the OCT interface. There's a lot of things going on this picture, which we'll see on our machine every time we turn it on. A lot of functions can be a bit daunting at first, but once you familiarize yourself with each of the tools, you find that there's a lot that you can do to help with your PCI. Here in the top right corner is the cross-sectional view, where we will do most of our plaque assessments and our cross-sectional measurements like lumen or vessel diameters. In the top left, we have the advanced view panel. We can put our angio-correg here, or we can also put our 3-dimensional reconstruction or 3-dimensional bifurcation assessments up here. Here's the lumen profile, which gives us the area of the lumen as computed by the software. In a longitudinal fashion, you can change it to the mean diameter as well. And this gives us a very quick assessment of where the stenoses along this vessel might be. And you can only get such a nice picture if your contrast clearance is good. That's why it's very important to have a good blood clearance when we perform OCT. Finally, down here, we have the L mode or longitudinal section. This is similar to what we have on IVUS. So some pictures to show how we can assess plaque on OCT. So just some simple things, as we all know, we've seen from Dr. Howe's talk. Here is a cross-sectional view of the vessel. In the middle, we have the lumen. And similar to IVUS, we always have an imaging core in the middle and a guide wire artifact. So these things are always seen when we do a OCT. The normal vessel layers, as already mentioned, include the media, which is this darker band. Maybe easier to see on this not so zoomed in view. So this darker band is the media that is bound by the external elastic membrane or the external elastic lamina and the internal elastic lamina. So these are important to identify because they are used for vessel sizing. Anything on the inside of the IEM is the intima, which in a healthy tissue should be thin, and anything on the outside is the adventitia. So these are some examples of the types of plaque that we might see on OCT: fibrous tissue, as we can see over here in this top right hand or 2 o'clock kind of region, it's a bright or slightly high backscatter image. It's homogeneous, so it's kind of smooth. Yeah, so that's fibrous plaque. Lipidic plaque on OCT appears dark. It is dark. It's got and it attenuates light, meaning when light approaches it or encounters it, it is absorbed by the lipid. Nothing can penetrate through, or rather, it doesn't penetrate through so well, and it doesn't get reflected back. So that's why we get this dark kind of image, and it's diffuse or poorly delineated. So we can't quite draw a line to say where the lipid starts or where the lipid ends. Also, with lipidic tissue of interest is the fibrous cap, or rather the thickness of the fibrous cap. So as you can see again here, because lipidic tissue, which is a low intensity signal, diffuse, not very well circumscribed. And here we have this cap, which is the covering, if you like, of the lipidic pool. When it's thin, less than 65 microns, we call that thin cap fibroatheroma or TICFA. So this is an example of OCT TICFA. If the cap is a little bit thicker than that, greater than 65 micrometers, we call that thick cap fibroatheroma. So thin cap fibroatheroma, as you know, is more vulnerable to rupture, and we have to be a bit more careful or treat our patients a little bit more aggressively when we see this. Now, calcium is, I guess, one of the things which are very different when seen on OCT versus IVUS. On IVUS, as you know, calcium reflects all the ultrasound waves, so you get a very bright signal, but because everything gets reflected back, you don't see behind the calcium. With OCT, light is able to penetrate through calcium, so we can see not only the superficial surface of the calcium, but in most cases also the deep border of the calcium. So calcium on OCT appears to be dark. It appears like a low intensity, gives a low intensity signal. It has very well delineated, very sharp borders, and usually you can kind of draw around it and mark it out. Just give you an example of what this might look like with IVUS. So with IVUS, you get a very bright signal on the surface, but you can't really see much behind it. So different types of description of calcium: eccentric versus concentric. Concentric basically means it goes all around the vessel. Eccentric means it doesn't quite. Deep versus superficial. Deep calcium is where you have a layer or a thickness, particular thickness of tissue between the lumen and the calcium. Whereas with superficial calcium, the calcium is almost in contact with the lumen. And this is the kind of you can't really tell between these types of calcium when you use angio alone, and that's why intravascular imaging gives you a little bit more information, because the strategies to treat these could be quite different. Calcific nodules or calcified nodules, these are microscopically very small little calcium nodules which protrude into the lumen, usually with overlying thrombus, and that's why you get the attenuation and fibrin, and usually in a segment which has a lot of calcium, so usually on an underlying calcium plate. And it's also, although not frequently, but it is also a cause for acute coronary syndrome. So the OCT calcium score is something the manufacturers like to promote to us as a benefit over IVUS. So with the OCT calcium score, you can assess the maximum calcium arc, maximum thickness of the calcium, the length of the calcium, and come up with this score, which if you score 4, meaning you get all these points, arc of more than 180 degrees, thickness of more than 500 microns, and a length of more than 5 millimeters, then you can kind of expect that your lesion is going to be hard to prepare. So you might want to use some adjunctive devices like rotational atherectomy or other types of atherectomy to prepare the lesion better. Other types of plaque, this is thrombus. So thrombus protrudes into the lumen. It's not really a plaque per se. It's not part of the intima. It's adherent to the vessel, but it protrudes into the lumen. Red thrombus, usually we encounter in acute cases like acute STEMI. There's high attenuation, like in this case. White thrombus usually is more organized, so it tends to, I guess, have a little bit more fibrous tissue, and it tends to be more homogeneous. This is an example of a cavity left behind by plaque rupture. So you can see that there's a hole in these sequential frames with a fibrous cap. Microchannels, which you can see very clearly on OCT and maybe sometimes on IVUS as well. So are these little tiny little vessels like that one over there? Yeah, which seem to go in and out the intima. They're not side branches. They just seem to, to course through the intima, and they're a sign or an indicator of vulnerable plaque. Spontaneous coronary artery dissection is another example of a situation where intravascular imaging might give us more information than angiography alone. This was a 45-year-old female who came in with non-SC elevation and whose angio was quite unremarkable. But as you can see, somewhere around here, she starts to have this separation of her intima away from the medial layer. So that's her entire vessel being dissected circumferentially. It's quite a long dissection and goes all the way back to the ostium of the LAD. Post-PCI appearances, stent, impossible to miss. It's very obvious, very high intensity, bright signal with these little like spokes that go out. So very difficult to miss metallic stents. This is what a BRS will look like, these little squares. So BRS is not made of metal, as we all know, or rather, except for the magnesium-based BRS. But most BRS are not metallic. So we get so the appearances are different. We get these little squares. I guess less relevant these days, but who knows? They may make a comeback. And post-PCI, obviously, we also want to assess expansion and apposition. This is a very extreme case of underexpansion. As you can see here, this stent is very squished. We can see on the longitudinal view on the OCT that clearly there is underexpansion over here. And underexpansion, the definition differs, whether it's 80%, 90%, 100%, depending on the trial, depending on the number that was used in that particular trial. But in general, we try and aim for a minimum stent area that is greater than 90% of the reference cross-sectional area. Malapposition, quite plainly, is the situation where your stent struts are not in contact with your vessel wall. On the, again, with the OCT software, they can detect apposition for you. And if you look at this example down here, all these red dots indicate that there is malapposition. You can adjust the parameters. In this case, I think it was set at 300 or 400, can't quite see. Yeah, 300 or 400 microns. So anything a bit above that, it will indicate as red. So that's another function of the OCT. It gives you a very quick assessment of where your malapposition might be. These are just some pictures which maybe you'll find helpful. These are co-registered images, meaning the same segment of the same artery, imaged with both high definition IVUS and OCT. This is an example of a normalish segment on IVUS and OCT. You can see that with normal vessels, you can, on either imaging modality, you can make out the layers. You should be able to make out the layers quite well. This is an example of fibrous and lipidic plaque. So on the left here, this is fibrous plaque seen on IVUS versus seen on OCT. And on the right here is lipidic plaque seen on IVUS versus OCT. So on IVUS, with lipidic plaque, we also have a darker or a lower intensity kind of signal. But because IVUS is able to penetrate a little bit better through tissue, we can still make out the media in this case of the vessel. So we can still make out the vessel size or the entire course of the media. Whereas with OCT in this particular segment, there's a lot of attenuation of light behind. And so we can only see the media over here from the 4 to 12 o'clock kind of position. And from 12 to 3, 4 o'clock, we can't really make out the media. Calcific plaque. On the left again, calcium, bright signal, but only the leading edge of the calcium can be seen. Everything behind it is not seen because all the waves are reflected back. On OCT, there is a degree of penetration through the calcium. You can see the deep border of calcium. This is tissue prolapse post stenting, very obvious on OCT. Needs a bit of imagination on IVUS. This is a distal stentage dissection, again on OCT. Can quite clearly see that there's this discontinuation. When I examined this very carefully on IVUS, I could kind of make it out, but maybe on the first pass you might have missed it. So, you know, one, I guess, criticism of the clarity of OCT is that we see a lot of these tiny little problems or tiny little things post PCI, and we don't know whether or not many or most of them need to be treated. So anyway, with regards to optimizing PCI using OCT, there's this algorithm which Tom Johnson briefly mentioned earlier, MLD max. So MLD is for the pre-PCI planning for your for the vessel, and max is the post-PCI optimization. So going through them, MLD, the first M is for morphology. So with morphology, you try and study the plaque, try and understand what kind of plaque you're dealing with. Is it a plaque that firstly needs stenting or not? If it's scat, for example, maybe you want to treat it medically. You want to look and see whether there's high-risk plaque, a lot of lipid. You want to see if there's a lot of calcium, because if that might influence the way you prepare your lesion. Length. With length, we want to look at obviously healthy or near or almost healthy tissue to land our stents. So we identify our references, and then we can measure the length quite reliably on OCT, also on IBIS. I usually allow an additional maybe 2 to 3 millimeters on each edge to account for error in measurement and to account for movement when we deploy the stent. And diameter, if at all possible, the convention or what's recommended is to use the EEL to EEL diameter. So with IVUS, most of the time we will be able to see most of the EELs. We can do that quite reliably. With OCT, if we can see it more than 270 degrees, then we should take the EEL to EEL, take an average of it, and then maybe downsize by 1/4 millimeter. If the EEL is not visible more than 270 degrees, then we may have to use the lumen to size our devices, and then we would upsize by 0.25 millimeters. Post-PCI, max, the first is medial dissection. So basically any dissection that is that looks severe. So a significant dissection is understood to be one that penetrates into the medial layer and involves more than 1 quadrant, more than 90 degrees of the arc. Apposition, small amounts of apposition may be acceptable, but usually if it's more than 3 millimeters of more than 300 microns worth of malapposition, perhaps you want to tack up the stent a little bit better. I forgot to mention, dissections are more common at the distal edge because the distal edge or the distal reference tends to be smaller. So our device, if anything, tends to be maybe slightly oversized at the distal edge. Dissections are more common at the distal edge, whereas malapposition is perhaps more common at the proximal edge, where the vessel is bigger than our device. And finally, expansion. You can compare the minimum stent area to the reference cross-sectional areas. More than 80% is probably acceptable, but more than 90% is optimal. And with the, I don't have a slide showing it, but with the automated OCT software, they can give you both apposition and expansion automatically. So that really helps you with your PCI. I'm just gonna skip through these 2 slides. Oh, I do have an example. So this is an example of a post PCI assessment of the stent. As you can see on the lumen profile here, the software has already recorded or calculated for us the expansion. So the expansion in the proximal half of the stent is 95%, expansion in the distal half of the stent is 97%. So that's above our recommended number of 90%. So this would be an acceptable amount of expansion. Okay, all right. So in summary, OCT provides high resolution intravascular imaging, and that gives us clear and often unambiguous images that really help facilitate plaque identification and PCI guidance. OCT, I would say, is superior over IVUS in clarity, the fact that it has a faster pullback in its assessment of calcium, and also in all the fancy tools and functions that are semi-automated and come with its software. The limitations of OCT surround its need for blood clearance, and I think that makes it inferior to IVUS for certain lesion subsets. And the bottom line is intravascular imaging has been proven to improve clinical outcomes. So I think we should really be using more IVUS or OCT in our clinical practice. Thank you very much.
Thank you, Dr. Chin. Very educational, very extensive review for the OCT Basic and application in daily practice. Because of time limitation, we will have a discussion session after the Dr. Frankie's talks. Dr. Frankie, can you give us a short recorded live case for OCT?
Yeah, sure. So so I will show a short recorded live case of OCT in a simple PCI in daily practice. So this is a 58-year-old man, smoker, hypertension. He complained of stable angina for 6 months. CT coronary angiogram showed mid-LAD severe stenosis and CT severe stenosis. So we plan to have an elective PCI with PCI from the right radial approach. So this is the case. So you can see with the angiogram, because disease in the very distal third, but moderate severe stenosis in the proximal LAD. So this is the alveolar wheel. So and then we can go to the cranial wheel. The second. So this is the cranial wheel. You can see along the fifth stenosis from the proximal to the mid LAD. You can see this is the left hemiaxial wheel. Again, very severe stenosis in the proximal to mid LAD. Again, the spider wheel. Left main okay. Proximal LAD maybe mild stenosis. And I would say it's just minor. It's a minor disease. So in this case, again, we would like to use the intracoronary imaging. So in this case, we use OCT. So I have to apologize to the panelists. So this is a very step-by-step preparation, but I would like to make it quick. So we open the OCT catheter, and then we use some pure contrast to flush the OCT catheter by attaching this syringe provided by Abbott to the side port. So we purge the catheter with 100% contrast. And then we take out the catheter. We can see this red dot here is the imaging catheter. So we insert the catheter on the wire. So this is where the image starts. So we park the image sensor distal to the lesion, and then we all know that OCT is contrast. So sometimes we can use the injector, like in our lab, we like to use the injector. Some people like to use the usual syringe. So this is a connection tubing. We try to make the tubing not too long because we really want to flush better. So we adjust the contrast volume, the flow, and the PSI. So we make sure we have a very good guiding. Make sure that our image is distal to the lesion of interest, and then we click the enable button, and then we inject contrast. And this is automatic pullback mode, so the OCT will activate by itself. So again, very good image here. But the first thing to do after the OCT is not look at the image, is to look at the patient hemodynamics. So because we inject a large amount of contrast, make sure that patient not have bradycardia or ventricular arrhythmia. Afterwards, we can analyze our image very, very clearly. So this is the OCT image. The quality is quite good. So I like to use the lumen profile to assess the OCT image. Also for the fellow, this is the so-called OCT registration. Again, very, very useful. We click the dots, click the co-registration, and then we click the dots, and we confirm. I click confirm. So the computer will adjust. So if we think the path is good enough, and then we click the registration. Now the pointer here is exactly where our image of interest is. So again, very, very useful technique to facilitate PCI. So for the region of interest, we can look at the plaque. We can see this is the more severe stenosis area. Some fibrous plaque here with a lot of attenuation. So this is a fibrofatty plaque in the mid-LAD. So again, just like IVUS, we look at the plaque composition and also the lesioning. And then we would like to look at where we want to land our stent. So you can see now we try to search the area of the distal landing. So probably maybe here, okay, here, some minimal plaque burden, some fibrous plaque here. So here is our distal stent landing zone. And then we go to search for our proximal stent landing zone. Again, very commonly, just like the case I showed in the IVUS previous case, this patient have diffuse disease. You can see the plaque extended from the proximal LAD through the first diagonal, almost at the osteo LAD. So again, we have to select and search where we would like to land our stent. So in this case, we try to land our stent here, just distal to the first diagonal, and we try to measure the lumen size and also the vessel size here. So from measuring the EM is around 3.5 to 3.6 millimeter. Okay, so now we know the stent is around 275 or 33 millimeter stent, and then we can know the proximal landing size is around 3.5 millimeter. All right, so we put in after some pre-dilatation, and then we put in the stent here, 3033. All right. So we try to use spider, make sure that we cover the whole lesion and just distal to the first diagonal, and then we deploy our stent. All right. So we deploy a stent, and we use an NC 3.0 and then a 3.5 short balloon to do some post-dilatation. So of course, afterwards, we get a post PCI OCT with the same techniques I described before. So this is the post-standing OCT, good quality images. Again, we can look at the stent expansion, stent position, and also the distal and proximal stent landing zones to see whether any stent edge dissection. So nowadays, the IBIS software, it can automatically calculate the stent expansion. You can see all the percentage here. So for now we are looking at the distal stent edge. Looks okay, no edge dissection. Right. Okay, we can do it frame by frame to see any edge dissection here. Okay, no stent dissection, landing quite okay. And then we will go to the proximal stent edge 3 seconds later on. All right, we look at the mid stent, again, expansion, satisfactory, appreciation, good. And now we're coming to the proximal stent edge. Right, because the stent now land on the plaque, we have to make sure that there's no very significant stent edge dissection here, because sometimes, because the stent land on the plaque, it will have some tendency, if we oversize the balloon, it may have some stent edge dissection. All right, so I would say the OCT result is quite satisfactory. As Dr. Johnson has mentioned, sometimes we have to decide whether we have to extend our stent beyond here or just to the ostium, because most of these patients have diffuse disease. So this is the final shot. Okay, so the angiogram, quite nice stent result. We have some moderate lesion in the mid already that we decided to treat it conservatively. So this is the caudal wheel to look at the proximal stent edge. Okay, again, some mild disease, diffuse disease, but we think that result is satisfactory. So that's the end of the case. So see whether you guys have any comments or questions.
Thank you, Frankie. Thank you, Frankie. Again, an excellent case. Maybe we can comment on both lectures together. Same approach. This time maybe European doctor first, and then see the Asian and Australia doctors' opinions. Yes.
I'm not from Europe, but I thought I'll just probably make a quick quick 2 comments. Again, Chiang, Frankie, congratulations. Those were great presentations, beautiful images. I think for the purpose of the audience, I just have 2 quick questions. The first one would be, operators would often shy away from using the OCT in patients with chronic kidney disease. Do you both then personally have like an EGFR cutoff where you would say, an OCT is an absolute no-no? And along the same lines, I've had a fair bit of experience using saline in the right coronary artery, but on the left, it's definitely a different thing altogether. I just wish to hear your personal experience with the utility of substituting contrast with saline and the overall accuracy of the images that you get, and whether you do encounter any form of difficulty, and whether this is a good alternative to contrast in such groups of patients. Thank you.
Okay, so maybe I'll give my opinion first. I guess I don't have an EGFR cutoff per se, but I would say that anything above 30 should be okay. There are of course ways where you can still save on contrast when you use OCT. For example, firstly, not using a side hole catheter, so you don't waste any contrast. You can, instead of doing, our usual practice is to maybe take a cine or a puff every time after we've done something like a balloon dilatation or a stent. So instead of doing that, we do it as part of an OCT pullback, for example. So we balloon and then we want to take an angio, but an OCT might be useful as well. We put the OCT down first and we take the angio with the OCT. So you kind of save one injection that way. And if you do it a few times, then maybe you can cut down a couple of injections. I think if there is significant concern about contrast tipping the patient into renal failure, I can think of not many situations, to be honest, where you have to use OCT and not IVUS. So if there's any concern at all, I would just defer to IVUS.
Yeah, I agree. Yeah, so same here. Not a cutoff of EGFR, but again, if we have some concern, we can just use IVUS, because there seems not much situation that we mandate to use OCT rather than IVUS. Concerning the use of alternative medium saline, yes, I agree that for RCA saline is good, but for left side it's very difficult. But typically, if we use saline, so the size estimation is typically a little bit smaller. So we underestimate the vessel size maybe 5%. So typically, if I use saline for RCA, the first run, particularly the pre-PCI OCT, I will still use contrast. But subsequent, if I want to do the reassessment, I mean the post-PCI, then I use saline. Yeah, that's what I usually do.
Yeah, thank you, Chiang and Frankie.
Thank you. Maybe Dr. Yoshiyasu, Sensei, do you have any comments?
Yes, thank you very much, Frankie. Very nice case. And I have one question. So in your Cath Lab, so who measure and who assess the OCT, the interpretation during the PCI procedure? I mean that for example, if we use the joystick, is a table side controller, we can measure and manipulate the OCT console by ourselves, or does anybody the measure the length or the diameter in your Cath Lab?
So yes, very good question. So in the past, actually, the rep from the ABIT happens to do all the measurements. But nowadays, after the COVID, actually, we all learn to do all this measurement by ourselves, either OCT or IVUS. So we usually do not use the tableside controller, although we know this is very useful, but usually we like to use the mouse just because we want to do it fast. So what we did after the pullback, we just, get off our gloves, or get someone to get some cover of the OCT console or the mouse, and then we do all the measurement ourselves. But I think it's actually good for fellows. Okay, if you know how to do all the measurements for yourself, it is OCT and IVUS, you know much more, and you will progress much faster when you do PCI.
Thank you.
Thank you, Frankie. Because of time, we have to move on. The next topic will be the limitation of OCT and IVUS. This is a very important topic because everything must have their own limitation, but this topic need to be explained by an experienced lecturer. Today, we are honored to have Thomas Johnson from Bristol. He is the Associate Professor and Consultant Cardiologist in Bristol Hospitals, University Hospital in UK. Thank you, Dr. Johnson.
Thanks, Solem. And fantastic presentations till now. And actually, many of the pitfalls and limitations have already been discussed, but it's a great pleasure to join you. So the outline for my presentation, I thought we consider some differences between IVUS and OCT, which have already been looked at in part. The practical indications I thought would be useful to look in my practice where I use OCT and IVUS, and then to consider complications and limitations related to intravascular imaging, and maybe some tips and tricks to enhance practice. So this has already been highlighted. The resolution is clearly different between IVUS and OCT, almost a 10-fold difference using the standard catheter. In fact, a high definition catheters, as we have in Boston Opticross HD and with the IVUS, the Volcano Revolution, we see a higher megahertz catheter with resolution then down to about 50 micron. The reality is that the resolution by OCT is by far and away the more superior, but the trade-off there is then penetration. And so IVUS gives you a penetration depth that allows you to look deeper into the vessel wall. And also, I think it's important to acknowledge that the pullback length for all of the IVUS catheters and for the Terumo OFDI catheter allow you a complete appraisal of the coronary vessel, where the Abbott OCT is limited to 75 millimeter pullback at its longest. And then, as Sidney Lowe highlighted, actually co-registration, I think, plays quite an important part and is going to become increasingly familiar in your practice in terms of using the intravascular imaging. So where do I use IVUS and OCT? And in fact, I use both in my practice. And I think it isn't about one being better than the other, but there are clearly situations where one is preferred. Osteal disease, this need to clear the vessel of blood with OCT makes osteal disease very challenging, and so IVUS is certainly preferred. And also due to that penetration depth, IVUS is better in large vessel. There can also be concern about injecting contrast for the purpose of the OCT acquisition, that if there is evident vessel trauma, so particularly actually in the iatrogenic setting where we've undertaken complex CTO, then actually IVUS is going to be the preferred modality to prevent that risk of propagating injury. And then we've just had a discussion about significant renal dysfunction. And again, IVUS would be preferred. And in fact, there's data to show you can do kind of zero contrast imaging. In my practice with OCT, I've actually started to move towards using a 50-50 mix of saline and contrast. And that works both in the right and the left coronary. But if there are concerns about image quality, then you kind of default back to using full contrast. Now, the resolution of OCT is then preferred when we consider, certainly, when we're challenged by ambiguity of the angiogram, or if we're wanting to work on a complex two-stent bifurcation, and the resolution of being able to visualize the stents becomes very useful. And we've seen that the software, certainly from Abbott, for the purpose of stent optimization, I think offers for us a far better means of assessing these criteria of dissection, apposition, and expansion. And then I think imaging is mandated really in stent failure. And again, the resolution of OCT favors its use in that setting. Where do I use it? Well, this actually extends some of the previous discussion. Haibo mentioned about the idea of IFR or FFR use. And I think increasingly we might turn towards this concept of precision PCI. The small green band is highlighting in my practice over the last few years where I've used both imaging and physiology. And I think cost is the deterrent. And so ideally, I'd like to be using it more, but maybe we do turn to using QFR, a method of using the angiogram, or maybe OFR, where you use the data from the OCT to offer you then also some kind of physiological surrogate. But you can see that there's a mix of IVUS and OCT, and actually simple angio-based intervention now is far less frequent in my practice, making only about a third of cases. So the first pitfall I'd like to expand on, which has been discussed in part through these presentations, is about the fact that we have to interact with our imaging. And Antonio Colombo put it beautifully that intravascular imaging cannot be used on an intention to treat basis. My concern would be certainly if actually imaging is seen as increasing the complexity of a procedure, that it's a badge of honor, that it's used just simply to increase the tariff and to show that you're doing something better or more complex. But actually, there is no point in doing it if you're not going to interact. And I want to share a case which I think very nicely kind of exemplifies those points. So this is a challenging case of a lady in her 50s who actually presented with chest pain, having returned from a long-haul flight to the States. She actually had a background of DVT, but was on rivaroxaban, so protected against further thromboembolism, and had a background history of type 2 diabetes and an ischemic ECG and elevated troponin. So the anterior ST changes and Q waves, she has a lesion in her proximal LAD, and in fact it had an angiogram 2 years prior, which showed that she's had quite marked progression over that time of this proximal LAD lesion. So my colleague moved forwards and undertook an OCT, which shows a high burden plaque, and you see kind of progressive layering of the atheroma. You see there evident on the panel on the right-hand side. And so proceeded to intervention at this point, OCT guided. So this is having deployed a 3 by 16 millimeter drug-eluting stent and post-dilated with a 3.0 non-compliant balloon to high pressure. And we see a well-opposed stent. We see the apposition marker showing complete apposition, and the stent appears well placed. Now, actually, if we come back and have a look at this, the patient unfortunately represented 4 days later with further chest pain and evidence of filling defect within the stent, which is suggestive of subacute stent thrombosis. You'll see that there's also reduced filling in the diagonal, and I have to say my feeling is this diagonal was probably the more likely culprit. Now, actually, that led me to come back and look at the original OCT. So this is my interpretation of the OCT, and we've already seen beautifully demonstrations from Frankie of using the software. But here we see, as we scroll up and down the vessel, that we see a very high burden of plaque. And so the decision about where you're going to land your stent, I think, is quite challenging. So there isn't really an area with absence of disease, but in selecting the landing zones here, mindful of the fact my colleague had placed a 16 millimeter stent, led me to choose these areas with, you see the focus of the stenosis in the mid portion. And here again, we're making an EEM to EEM measurement. So it's coming up at about 4 millimeters proximally. But actually the lumen, if you measure, is coming up as 3.5, and then it's rather eccentric. So we see that in the shorter plane, it's coming up around about 2.7. And I think, again, these algorithms are useful, but we have to be willing to tailor. And so although the EEM may be the better measure, sometimes you have to use the lumen rather than the external elastic membrane to try and avoid potential injury. So again, we see the vessel is around about 4 millimeters by EEM, but again, very eccentric luminally. So I think a selection of a 3.0 stent was very appropriate, although algorithm might say 3.5. And the length of 16 millimeters seems about right. Now, as it happens, when you go back and look at the stent that was deployed, they deployed it about 8 to 9 millimeters from the ostium of the LAD. So actually going back and measuring exactly where they landed the stent, you'll see that in relation to where I've planned to place the stent, they've actually placed it significantly downstream. And so again, this comes back to Sidney Lowe's point that, the use of the co-registration, the ability for us to be absolutely precise in terms of our decision-making is key. And so one of the difficulties about using the imaging is that it then exposes potentially error downstream. And I think this may be one reason why then colleagues actually shy away from using the technology in the first place, because it's quite revealing. So here we see that the stent has actually been deployed into a slightly smaller downstream reference zone. So thankfully, the 3 millimeter stent is appropriate, although it may have been slightly undersized to the proximal vessel. So if we then look at the assessment of the criteria, so we've talked about ultimate criteria, we've talked about trying to get an MSA above 5 or 5.5 by consensus. If we look at the expansion, we see expansion that's exceeding the 90% that Dr. Chin mentioned. So all in all, this is looking very good. We see evidence of a small dissection on the proximal vessel, on the proximal stent edge, but that's not unreasonable to leave, certainly within the parameters that were defined through the MLD max algorithm. Now, I think what's interesting is that this patient actually came back with that stent thrombosis and underwent IVUS by another colleague. So we can see here that the stent has been further post-dilated with a non-compliant balloon. And the IVUS evaluation, I'm sorry, this has been accelerated for the purpose of time, but it shows quite interestingly, the differences between what the IVUS show and the OCT, and I'll show on the next slide a direct comparison of the IVUS and the OCT images. But what we see here is we see evidence of the dissection that was apparent on the OCT. We see actually a vessel that is rather large, so a vessel area of 14, and we see that the stent has been deployed into an area of increased plaque burden, which explains why we see that dissection. As I showed you, probably I would have deployed the stent more proximal. And then we see that the stent, although it hits the parameter of 5 millimeters squared, it's actually quite small for the vessel that it's treating. And when you look at the OCT and the IVUS, I think this is probably the most important point I want to make through the presentation, is that if you are using both modalities, you have to be very aware of how different the images are using light and using sound. And so on the left panel with the OCT, actually, I think your eye is drawn to the stent and to the lumen contour. Whereas in fact, on the IVUS, your eye is very much drawn to the external elastic membrane. And so the stent looks very small on the IVUS image because you're kind of embracing it through looking at the entire vessel. Whereas on the OCT, it looks very reasonable because again, your eye is focused upon the lumen contour. And I think that's quite an interesting difference between the two imaging modalities. Now, having said, that case is an example maybe of underreacting to the imaging, I think there's also a risk of overreacting to imaging. And so we've heard beautifully about the importance of defining calcium. And this is a case example I've used many times before on complications symposia, but looking at this idea of creating injury. This is hideously complex disease in a lady in her late 80s. And actually, after lots of discussion about surgery versus intervention, it was deemed appropriate to intervene on her, stenting the LAD and then the circumflex. Deployment of devices into the circumflex was challenging, but because there was a stent in the LAD, you could use an anchor balloon. This is deployment, then using a guide extension, buddy wire. This was actually a long time ago using bare metal stents, but in a lady with very, very high and active bleeding. And the OCT following deployment of the stents here, you'll see shows very extensive calcification within the stented segment, and particularly a nodule of calcium in the more proximal vessel where the stent is then failing to oppose to the vessel wall. And this is where perfection is the enemy of good. And so focusing on that nodule and post-dilating more aggressively with a non-compliant balloon to try and achieve better apposition resulted in this. And so again, I think the reaction to your imaging is potentially, can be potentially harmful. And there's a definite regret at the point of having deployed this non-compliant balloon to high pressure, where you then have this catastrophic perforation, which was thankfully dealt with by deployment of 2 covered stents. And actually the patient has done remarkably well. The next, and this was beautifully illustrated again by Dr. Chin, is this issue about quality of image. We heard in the very first presentations about IVUS that there's a need to be mindful of air within the catheter when you have a catheter like the Boston or the Revolution catheter, where you must purge and flush the air out. And then similarly with the OCT, there's this need to get rid of the contrast, get rid of the blood using contrast within the vessel. Now, this is the French experience from Nicolas Amibile. And we see here the use of 15 mils of contrast, and actually the superiority of images done with 25 mils. I must say in my practice, I've never used that much volume and instead turned to using other tips and tricks. So particularly in the left system where half of your contrast is lost down another limb of the coronary, it's really important to consider coaxial guide engagement, and then also consider using a guide extension so you can actually then extend the guide liner into the LAD or into the circumflex, depending on which vessel you're wanting to image. I also use a contrast pump. So Frankie showed the use of the ASYS device. I will use a MedRad pump because we don't have ASYS available, and use very similar settings to that which was shown from Hong Kong. So tending to use maybe 16 mils of contrast routinely, a 4 mil per second rate at 300 PSI. And there's always concern that could actually, cause injury, but actually Evelyn Rigar showed beautifully with use of a pressure wire down the vessel but actually it results in a very small rise of only 10 to 15 millimeters of mercury of pressure intracoronary. Having said that, we do have to be mindful that instrumenting vessels carries potential risk. And this is an early example of mine from back in 2011 in a patient who actually had fairly clear-cut evidence of spontaneous coronary artery dissection with very tortuous vessel. And in my practice now, I would never consider undertaking an OCT, but I was really keen to try and ascertain the diagnosis. And in doing so, patient had chest pain and ST elevation immediately after the OCT, and you see clear evidence of a very extensive dissection. And these are really hideous images by OCT, where we see that the vessel really has sheared from the left main down the LAD, which thankfully was restored by OCT-guided intervention, stenting the left main through to the mid-LAD. But we've seen even in historical trials like Prospect that actually instrumentation of coronaries does carry a risk. And so in Prospect where multi-vessel IVUS was undertaken, there was an injury rate of about 1.5%, 1.6%. So we must be mindful of that. So my summary, and really just extending what's already been discussed through the fantastic presentations of earlier, it's really important to understand the pros and cons of IVUS and OCT. And I wouldn't become an IVUS or an OCT user. If you're lucky enough to have both modalities, then you'll find there are cases you'll want to use one or other of the imaging modalities. It's really important to interact with the imaging, but as I've shown in the setting of the calcium, not to sometimes overreact and potentially cause problems. Co-registration undoubtedly reduces contrast use, and I think enables you to guide your procedure from the very beginning to the very end. And I think it's always important to consider that invasive imaging does carry a risk, and so you must consider your indication carefully and always take care, but most importantly then, enjoy the experience. Thanks for your attention.
Thank you, Dr. Johnson's excellent talk. Dr. Cindy Low, do you have some comments?
Yeah, look, I think that's the most amazing talk. So that was wonderful. So I thank you very much for that. I just want to mention about getting really good quality images, particularly for the fellows, about those 4P things: position, purge, a bit of a try, and then the pullback. But the thing that I found a lot with teaching fellows in the lab is nitroglycerin. So except for CTO cases, we mentioned we didn't want to actually inject anything down the artery using IVUS, and mostly IVUS is kind of king in CTO PCI. I think that probably we need to be very conscious of nitroglycerin spasm, because we're sizing on vessels, particularly in acute coronary syndromes. Sometimes we're just really undersizing them, they're spasmodic. And so nitroglycerin is a key. Make sure you get a good dose down the artery. So.
Yeah, good quality of OCT image is very important. I think for all the fellows, this is something basic. Do you have any tips and tricks to get good image? Henry, do you have any tips and tricks to share? I know you do lots of OCTs.
Actually, I think learning OCT is difficult, especially in the initial stage. I think the first thing is to learn how to do a good image. Second is learn how to interpret. And third is how to incorporate the information to change your practice. So first is how to get a good image. I think coaxial of the guiding is very important. So most of the time nowadays, we are doing the wide radial axis. And I would say mostly clockwise turn, the guiding would cause it the coaxial engagement. So because during the engagement of the guiding or the diagnostic catheter, usually I would do the clockwise rotation to get into the left cusp and engage the left main. But during the course of the procedures, the guiding would counterclock itself back, and the reflex action is to push in the guide to get a more deep engagement and do the OCT, but this is wrong. And mostly is to pull back the guide, clockwise rotation to make it more coaxial and to engage the guide a little bit and test the puff and make sure it's engaged before you do the injection. And given nitroglycerin is very important and pre-dilate if very severe lesion, because if you don't have a good nitroglycerin dosage, you may undersize the vessel a lot. And secondly is how to interpret the image. And it's best not to learn during the case, but rather you come out of the lab and you get into the OCT machine and play it yourself, ask the expert about how to interpret the image. And thirdly is how to use the information to change your practice. Say like the case just shown by Doctors Thomas Johnson is very good illustration. So if you have very heavily calcified vessel with eccentric calcified nodules, and it's very tempted to blow with a big balloon or higher pressure, and it will cause problems. So in this case, very heavily calcified eccentric nodule, I would probably undersize by even 0.5, but go 24, 26x. Rather than matching the vessel size and burst the vessel. So this learning how to react with the image like the is very important. And I think the best thing is to learn after the case that you are more relaxed and can teach by some of the expert operator.
Thank you, Henry. Paul, do you have any comments? I see on.
I am. It's not fair, isn't it? Everyone has spoken now. One thing I find useful when I come to, because I don't use power injector to get OCT, I do hand injections. I tend to take a 20 ml syringe, luer lock, and I tend to disconnect the manifold and directly connected the 20 ml syringe to the copilot or whichever device you use. And that cut out a lot of resistance. So when you hand inject, you get much better injection and much better flow and pushing the blood away. So that's one of the tricks that I thought I'll share.
Yeah, thank you, Paul. That's important tips. Doja, do you have any tips and tricks to share?
I have one comment for the Thomas Johnson's presentation. So I think Tom Johnson's presentation nicely demonstration of a little bit the limitation of OCT guided PCI. Simple lesion, I think that for interventionist, vessel diameter is the most important parameter we have to know during the procedure. But the OCT, sometimes we can see the trajectory size of vessel. So in many cases, a simple case, OCT can guess based on the reference vessel diameters if there is a normal reference vessel. But diffuse disease or left main disease or very tortuous disease, we cannot guess the vessel size accurately. So in such a case, I think we have to use the IVUS instead of OCT. In addition, I think that for the fellow or the beginners to start the coronary intervention, I like to recommend to start with the IVUS first and move to the OCT practice. This is my idea.
Thank you. Dr. Ansan, do you have any comment about IVUS versus OCT or?
Yes, actually, I want to have one comment. So for young fellow, so I think the very fundamental difference between these two modalities is, first of all, the plaque burden. If you have a huge lipid plaque versus the IVUS. So IVUS, for a very huge lipid plaque, you can see the vessel size. Sometimes out of your expectation, you ever get what's called a possible vessel remodeling. So if you trace along the vessel contour from distal to proximal, like for example 3 to 4 mm, and inside the lumen of the lipid-rich plaque, you may have this sort of positive vessel remodeling, and the vessel will grow up to, for example, around 5 to 6 millimeters, which can be able to give this piece of imaging by OCT. So OCT gives you the very excellent anatomical details inside the lumen, but for very huge plaque burden, I think IVUS can still have extra role. So the operator need to understand the pros and cons. I think Johnson have clearly demonstrated what's the pros and cons. I think this is the last piece of information I want to let the fellows to take point of.
Thank you, Alan. And Doja, do you have some comments?
Thank you, Tom, for a fantastic presentation. So I have one small question about, So either IVUS and OCT have their own advantage and disadvantage. So in some special cases or region, we need both of these two imaging modalities, like you show one case. So what do you think the future of the dual imaging modality? For example, we now have OCT IVUS and OCT news and IVUS news. So what do you think about the future?
Yeah, I think there absolutely is a place for combination catheters. So I know Terumo have an IVUS OCT catheter that's due in the next year or so. There's another device out there, as you say, IVUS nears we haven't talked about, but for the moment it's academic, but I think it will become an increasingly useful clinical tool for that purpose of looking, as Dr. Ahn said, looking at the vessel size with the IVUS, but actually having the resolution of the OCT to have greater clarity of the other elements that IVUS doesn't pick up so well. So combination will be the future, I'm sure.
Thank you. Maybe because of time, and thank you for all the speaker and also the all the audience. They stay together with us. I know we are tired, but that's not the end. We have in the coming time we will have Professor Jensen, who is the associate professor and the medical director in the B-Born clinics in Germany. He will going to share with us some OCT and IVUS case as the final talks in these functions. Thank you, Chris. Chris, you are mute. Chris, sorry, Chris, you are mute.
Okay. Sorry.
Okay.
Sorry.
Okay.
Yeah, thanks, Lam, for giving me the opportunity to round up this course, and then thanks for all these excellent talks. I brought you two cases that strike me in clinical practice over the last couple of years of ambiguous lesions where I tried to find out what the problem was. And I think what shows the capability of imaging. So first of all, it's a nice old lady, 75-year-old, had no prior history, and she came in during the emergency with an acute presentation of ST elevation in inferior leads. So I took her to a Cath lab, and so this is the angio of the right. The right was quite tertious, quite heavily calcified, and as an ex-smoker, is quite typical in my region. And so I managed to bring down a guide wire. It was quite difficult. The vessel was occluded then, and so there I managed to. I had to stent, like a long stenting, like 3 or 4 stents, 4-0, and this is the final result of the right. So to complete the angio, I took a shot in the left, and then this structure hit me here on the LRD. In the first thought, I thought it was moving. It was a round, hazy structure in the mid LRD. I magnified it a little bit over here, but when I looked at it closely, it stayed at the same position. The patient was having no angina anymore, hemodynamically stable. So I wondered whether it was a thrombus, maybe some emboli or some calcium, because she was quite heavily calcified anywhere, or some vegetation or so. And so I put down an IVUS look at the IVUS run. So these are the run from the mid LID to the left main. And when I put down the probe was stuck in this area over here. So let's wait for the beginning again, and then so that's the part where the probe was stuck over here. So then, and you can appreciate that there's quite a bit of calcium in this vessel, nearly 360 degrees, with heavily penetration into the depth of the vessel. And the funny thing is that it looks like a nodule, and a really big nodule in the mid LID. So I checked for the minimal lumen area, and this was here in the distal part where the nodule was 7.6 square millimeters, in the middle third 6.6, and in the ostium of the LID 7.1. So luckily, a lot of calcium, but minimal lumen area was big enough so that nothing had to be done. But still, it's a calcific nodule, and this can bring you into deep trouble if you don't know what it is. So in this case, nothing had to be done, so it's a good thing. The second thing is it allowed me to find out what it was and to differentiate it from different structures, and I could appreciate the calcification. And if there should be a treatment, then I know in advance how to adjust my treatment strategies. Sometimes these calcific nodules causes ACS, which is luckily a really small substance of ACS. And then there's some thrombus on this calcific nodule, and they erupt and cause acute occlusion and acute coronary syndrome. This makes it difficult to bring the stent down over this nodule, and you have to be aware of it and be prepared to prepare the vessel in this area, maybe a rotablation or a cutting balloon or so. Otherwise, you get really big troubles afterwards. The second case that I want to show you is a man. He's a little bit younger, 57. Had no prior cardiovascular history. He was a heavily smoker and had a partial lung resection due to carcinoma. Presented with stable angina, and the GP already ordered a scintigraphy, myocardial scintigraphy, and this showed inferior ischemia. So we took it to the Cath Lab, and the left coronary artery system looked pretty unremarkable, and that's the right. So it's a right radial approach. I think it's a radial tick, and then you see this strange structure here in segment 1 and 2 of the right coronary artery. I stop this, and you can appreciate it looks a little bit hazy, and it's a long structure. It's a big vessel, and we couldn't really make out, and you can't really decide what it is on pure angio. So in this case, we took an OCT, put on the wire, and with an OCT run, it looked even more pronounced now, the haziness with the wire down and the OCT probe down. And then that's the run. So from distal to proximal, you see some plaque. And then it gets strange. With a lot of holes in it. Resembling maybe a Swiss cheese. I think this is one of these images that you see maybe once or twice in your lifetime during your clinical practice. There are some case reports out there. So quite a big vessel, and these are the still frames. So you see some thrombus here, and then depending on the part of the RCA, you see the true lumen and then the Swiss cheese appearance, right? So in this case, so this was an recanalized thrombus or the Swiss cheese disease. So we could identify it, we could differentiate it. We saw a hazy structure. We found the reason for the angina and the ischemia, and we could appreciate the extent and length of disease and the size of the vessel as well. Took a PCI, was stenting, the longest stent we had, and then proximal stent as well. And this is the run afterwards. I think you can appreciate the good apposition. At that time, we didn't have any fancy automatic assessment of apposition. So it was all eyeballing. And we took contrast agent, no saline, with a well-expanded stent in the RCA. Okay. So 3 parts looked well done. The stent was opposed and the size of the vessel matched. So in this case, we had pre-PCI, or we had the differentiation of the hazy structure with the OCT. We had the post-PCI OCT, so we could assess for the stent apposition, the effective stent optimization if needed. And overall, in these 2 cases, intravascular imaging provides a diagnostic clarity and facilitates the treatment strategy. And I believe that it should be part of modern interventional cardiology, and the thresholds to use it should be very low. Thank you.
Amazing case, Professor Jensen. Thank you very much. Any comments from the panelists? Dr. Honda, do you have any comments on this talk?
Yes. Dr. Christoph, thank you for sharing the excellent cases, and these are very interesting. I have one question regarding the first case. The first case have IBIS images, and as probably as a culprit lesion, and there's a dark structure around the calcium. And I'm not questioning what was that on IBIS image. And you mentioned that calcified nodule may cause the attack, but I would use OCT for further investigation of the lesion. Did you consider the use of OCT imaging for that lesion?
So luckily in this patient, the ACS was caused by the occlusion of the right coronary artery. So the calcific nodule in the LID was just a bystander finding that we imaged. I decided to go for IVUS for 2 reasons. First, I already used a lot of contrast agent for the right because it was way longer than the 2-3 images that I showed you, and it was tortuous and she was in pain and a lot of calcium, so it was hard to get down all the stents. And the second thing is, at that time, I didn't have any OCT in my lab. So there was 2 good reasons to use IVUS. We know that sometimes there is a lot of thrombus on these calcific nodules, but luckily they only make a small subset of ACS. So as in this case, it was asymptomatic, and even the follow-up, nothing happened. So it's just a strange finding on an image without any resulting treatment.
Thank you, Holt.
Thank you. Maybe I think we enjoy a very good afternoon, and it's time for the end. And Jack, would you like to do the closing?
So thanks, Olam, and thanks, Dr. Ahn, for the wonderful moderation. I'm just here to say the opening and thank you. I hope the audience and the fellows enjoyed this course. We endeavor to do more of this. I do hope the audience and the fellows who are keen to learn intravascular imaging and physiology do become as enthusiastic as my crowd of faculty here. You can see they are really enthused and they are really eager to share, and they are very passionate about this stuff. And I'm really appreciative of all the speakers and the panel for their contribution and their great comments. We will have a follow-up session to this, and I would like to again thank the attendees for staying throughout the 2 hours plus. So thank you very much, and I would like to wish everyone a good rest of the weekend, and do keep safe during these pandemic times. Thank you, and goodbye.
Thank you.
Thank you very much.
Thank you all the unconditional help from all the panelists. Thank you. Thank you. Bye-bye.